Good morning to all. This is Dr. Suganya from Pathology. Today we'll be seeing about multiple myeloma part 2. Last class we have seen about plasma cell dyscrasias and we have outlined about the multiple myeloma and its pathogenesis. Today let's see about the clinical features, morphology and lab investigations of multiple myeloma. Here is the case history. A 65-year-old female presented with fracture femur following non-trivial fall. She had low backache for past 2 months. So what's your diagnosis? She has a fracture of femur following a fall. It can be due to non-trivial fall. So it's not due to trauma. It is called as pathological fracture. And she also has a low backache. So most probable diagnosis is multiple myeloma. The clinical features of multiple myeloma are due to three things. First is plasma cell growth replacing the bone marrow. Second, due to excess immunoglobulins. Third, due to suppression of normal humoral immunity. So you all know that the bone marrow is completely replaced by plasma cells. So it results in bone resorption and hypercalcemia, which causes punched out lesions involving the flat bones, particularly vertebra, skull, sternum, ribs and clavicles. This manifests with bone pain, pathological fractures and compressive myelopathy. This compressive myelopathy is due to vertebral column collapse and compression. And there will be increase in serum uric acid. This is due to increased cell turnover. And moreover, the osteoclasts are stimulated, resulting in bone resorption and generalized osteoporosis. Decreased immunity will also lead to infections. Next, the Benson's proteinuria, amyloidosis, hypercalcemia and hyperuricemia result in renal damage and failure. You also have the hyperviscosity syndrome. This results from increased viscosity of blood due to immunoglobulins. First is the visual impairment due to increased venous congestion. So you will be having papilledema, hemorrhage and exudates causing visual problems. Then neurological problems like headache, dizziness and stupor. Third thing is the congestive cardiac failure. Then can have bleeding due to coagulation abnormalities. The cryoglobulinemia results from precipitation of the macroglobulins at low temperature, which causes Raynaud's phenomenon and urticaria. Now we will move on to the standard workup of multiple myeloma. First and foremost is the immunoelectrophoresis. This is the gold standard for diagnosis. Immunoelectrophoresis should be done both in the serum and urine to find the monoclonal heavy and light chains. Next, complete radiographic bone survey for lytic lesions. Then peripheral blood and bone marrow aspirate or biopsy. Then blood chemistry studies to evaluate the renal function, total protein, albumin, calcium and uric acid. Serum electrophoresis shows an abnormal M spike that is in the gamma globulin region. Similarly, monoclonal spikes will also be seen in the urine. The 24 hours urine for total protein and electrophoresis is usually done to confirm the presence of Benson's protein. In the normal electrophoresis, peak will be seen only for albumin and globulin will have only a small hump. Whereas in case of multiple myeloma, there is a sharp monoclonal spike in the gamma globulin region. Here you can see a monoclonal spike in the gamma globulin region. And here IgG is predominantly increased and similarly in light chain kappa is increased. In the radiological survey, you can see the characteristic punched out lesions in the skull and other bones, causing osteolytic lesions. Now let's see about the blood investigations. In the CBC, you will be having anemia, leukopenia and thrombocytopenia with an increased ASR due to hypergammaglobulinemia. In the peripheral smear, you can see the rouleau formation. In the later stages of myeloma, there will be increase in plasma cells. If it is more than 20% of the WBC count, it will result in plasma cell leukemia. In the urine, you can see the Benson's proteinuria. Now moving on to biochemical investigations. To assess the renal function, we have to do blood urea, creatinine and electrolytes. And serum calcium and uric acid levels are usually increased. In case of complications, serum alkaline phosphatase is also increased. And there will be increase in serum protein level, but with an alteration of the albumin globulin ratio. The most important assessment for a prognostic factor is serum beta 2 microglobulin. This is the peripheral smear showing rouleau formation and plasma cell leukemia showing many plasma cells. Bone marrow is heavily infiltrated by atypical plasma cells which can be demonstrated by either bone marrow aspiration or biopsy. Usually the plasma cells account for more than 30% but can be even less than 30%. These cells resemble the normal plasma cells but are atypical with prominent nucleoli or abnormal inclusions containing immunoglobulins. Some variants like flame cells have fiery red cytoplasm and mott cells have multiple grape-like cytoplasmic droplets. These inclusions can be either cytoplasmic or nuclear. When it is cytoplasmic, they are called as Russell bodies. When they are nuclear, they are called as Dutcher bodies. The replacement of the marrow by plasma cells results in pancytopenia. This is the bone marrow picture of multiple myeloma. You can see the binucleate atypical plasma cell and mott cell with multiple grape-like cytoplasmic droplets. So in this picture, you can see the Russell bodies, which are nothing but the cytoplasmic inclusions. In histopathology, they appear as pink cytoplasmic inclusion. Dutcher bodies are the intranuclear inclusions, and flame cells are nothing but plasma cells with fiery red cytoplasm. Next commonest organ to be affected in myeloma is the kidney. Usually in 75% of the cases, the excess immunoglobulins precipitates in the renal tubules. So they will be associated with proteinaceous cast, mostly of Bence-Jones proteins, obstructing the distal convoluted tubule and collecting duct. Surrounding the cast, you will be having a multinucleated giant cells. The epithelial cells adjacent to the cast become necrotic or atrophic. You can also see metastatic calcification, light chain amyloidosis of the renal glomeruli and vessel wall, and finally, due to infections, you can see bacterial pyelonephritis. This picture is the Congo red stain showing amyloid deposits in the renal blood vessels. So far, you have seen the clinical features, morphology, and lab diagnosis of multiple myeloma. Coming to the diagnostic criteria, you have both major and minor criteria. Major criteria is bone marrow plasmacytosis of more than 30% of the marrow cells with extraosseous plasmacytoma, monoclonal gammopathies. If it is IgG, it should be more than 35 gram per liter or IgA more than 20 gram per liter. Urinary light chain excretion more than 1 gram per day. In minor criteria, the plasmacytosis is less than 30%. You can have either lytic bone lesions or M component is present or reduced serum immunoglobulin. So the diagnostic criteria should fulfill one major and one minor or three minor category. So the staging of myeloma is done by Dury-Salmon. It is called as Dury-Salmon staging. In stage 1, patient will not be anemic. So hemoglobin will be more than 10 with normal serum calcium, bone marrow extrait or single plasmacytoma. Only there will be a small amount of monoclonal immunoglobulin with low myeloma cell mass. In stage 3, patient will be having anemia along with hypercalcemia and multiple bone lesions. The monoclonal immunoglobulin is markedly raised with high myeloma cell mass. Intermediate between these two is stage 2. So the staging is Dury-Salmon staging for multiple myeloma. As I have said earlier, beta 2 macroglobulin is an important prognostic marker. The levels more than 6 mg corresponds to stage 2 and 3, hence poor prognosis. The other poor prognostic markers are amyloid, IgA, M protein and CD10 myeloma cells. The treatment for myeloma is standard chemotherapy with prednisone and N-phenylalanine mustard. And you can also give supportive therapy for other complications. Death most commonly due to infections or renal failure. Finally, a few words about lymphoplasmacytic lymphoma. It is a B-cell lymphoma which occurs in the elderly, commonly during the 6th to 7th decade of life. They secrete monoclonal immunoglobulin, resulting in Waldenstrom's macroglobulinemia. There won't be any bone destruction in this case. The bone marrow will show lymphocytes, plasma cells, plasmacytoid lymphocytes and mast cells. And in PAS stain, you can see the intracytoplasmic and intranuclear inclusions like Russell bodies and Dutcher bodies. Here also due to increased production of the M protein, there will be hyperviscosity syndrome. So lymphoplasmacytic lymphoma, the histopathological picture shows polymorphous population of lymphocytes, plasma cells and plasmacytoid lymphocytes. This is the bone marrow aspirate showing the plasma cells and lymphocytes. The most common monoclonal immunoglobulin in lymphoplasmacytic lymphoma is IgM. So this week's assessment will be write the morphological features and lab investigations of multiple myeloma with suitable diagrams and submit it by Saturday. Thank you.